Hi, my name is Dr. Sawsan As-Sanie at the University of Michigan, and I'm here to answer some excellent questions that we've received on our education seminar. So this is a great question on when should we refer patients to an infertility specialist in someone with known or highly suspected endometriosis. And so in a typical low-risk patient without any obvious known factors for infertility, most gynecologists would advise a patient to try to conceive for up to a year before getting referred to an infertility specialist. But in any patient with a known risk factor for infertility, and endometriosis is certainly a risk factor for infertility, I would say I would typically refer a patient after trying naturally to conceive for at least 4 to 6 months before referring them. And this is really to try to facilitate a quicker time to conception for these patients who have known risk factors. So this is a really great question, and relugolix and elagolix are both FDA-approved medications for the treatment of endometriosis-associated pain symptoms. They are similar in many ways, but dissimilar in several important ways. And so the decision on which to use definitely varies from person to person. Both of these medications do tend to be well tolerated by patients, but it's important to know that elagolix, the formulation that's used specifically for endometriosis, comes in 2 doses, and neither of these doses include add-back therapy. And so you have moderate to complete suppression of estradiol production in these patients without any add-back. This does lead to a limitation in how long you can use these medications. So for the lower dose of elagolix, it's approved for use for up to 2 years. And for the higher dose of elagolix, it's approved for use for up to 6 months. Relugolix is only available in the United States in combination with estradiol and norethindrone acetate add-back therapy, and tends to be very well tolerated by patients without the common side effects of menopause-like symptoms with low estrogen levels that you would see in elagolix. And so for this reason, it tends to have really excellent tolerability by patients because you have little to no menopause-type symptoms that you see with GnRH analogs that do not include add-back therapy. In most situations, I would say that both of these medications would be considered second-line therapies in terms of hormonal options relative to more commonly and well-known medications such as oral contraceptive pills and progestin-only methods. And this is due to the known efficacy of these other well-established medications and often lower cost as well as excellent tolerability. But in patients who either don't tolerate these first-line therapies and or don't have adequate control of their symptoms, then we would often move on to a medication such as a GnRH analog, which includes either relugolix or elagolix. In terms of deciding how to choose, this is definitely a shared decision with patients discussing the known data that we have about it. Both medications have shown excellent efficacy in the treatment of the most common endometriosis-associated symptoms, which include dysmenorrhea, non-menstrual pelvic pain, and for some patients, dyspareunia, which is pain with sexual intercourse, also significantly improves. There are some differences in indications and contraindications. So it's important to note that relugolix combination therapy, which includes estradiol, will be contraindicated in any patient who has a contraindication to any type of estrogen therapy. So, for example, patients that have had a prior thrombotic event or patients who are smokers, for example. And so that should definitely factor into decision making. So this is a great question, and one of the most common situations in which we see patients in our referral clinic for chronic pelvic pain and endometriosis. So unfortunately, while the usual therapies such as hormone therapies and surgery are absolutely the gold standard treatment for patients with endometriosis, up to 15 to 20% of patients have some degree of persistent pain despite these usual therapies. We can't really predict ahead of time who is going to respond and who's not going to respond to therapies. And so it certainly is important to use these usual therapies in patients with the hope of improvement. But, in those patients who don't respond to usual therapies, the first step is do we have the right diagnosis? Now, while endometriosis, is confirmed in many of these patients, we really need to do a comprehensive evaluation of their pain symptoms and look for other contributing causes. We do know that in patients with endometriosis, they are much more likely compared to the general population to experience other chronic pain conditions, so things like irritable bowel syndrome, bladder pain condition or interstitial cystitis, vulvodynia, fibromyalgia, chronic low back pain. All of these conditions are anywhere between 2 and 16 times more common in women or in patients with endometriosis compared to the general population, depending on that specific condition. So doing a comprehensive evaluation for other chronic pain causes is incredibly important. And if you identify one of these, it's important to get the patient to the right treatment strategies for it. Another really common and infrequently diagnosed or underdiagnosed condition in patients with endometriosis and chronic pelvic pain is pelvic floor myalgia or myofascial pain. So that's sort of pain related to tightening and contraction of pelvic floor musculature. The primary treatment for this is pelvic floor physical therapy. And so identifying patients who have coexisting pelvic floor myofascial pain is absolutely critical in the care of these patients. We also know that, unfortunately, for any person who suffers from chronic pain for long periods of time, they can have changes in the central nervous system, such as central sensitization, that can cause persistence of pain even when the initial sort of insulting condition is treated, such as the endometriosis. And there are a lot of both pharmacologic as well as non-pharmacologic therapies for central sensitization, including medications as well as behavioral therapies such as exercise, yoga, acupuncture, acupressure that can often be helpful as supportive adjunctive therapies for these patients. This is a great question and often a really understudied and question that is not talked about a lot in women or patients with endometriosis, and that is of painful sexual activity. So painful sexual activity is an incredibly common and, of course, very devastating symptom for any patient, and including patients with endometriosis. And anywhere between 10 to 50% of women with endometriosis experience painful sexual activity. In some studies, it's often reported that painful sexual activity is one of the most distressing symptoms that they experience, and sometimes even more distressing than their menstrual pain or their other non-menstrual pelvic pain. So when you see a patient with endometriosis or suspected endometriosis, it's incredibly important to ask patients about whether or not they experience painful sex, and if this is a symptom that they would want to be specifically evaluated and treated for. But it's also important to note that in a patient with painful sexual activity, while endometriosis is one potential cause, there are actually many other potential etiologies to painful intercourse. Just to sort of give a very sort of brief overview of how we would approach this, the types of questions that's important to ask is the pain that a patient experiences, is it primarily with entry or is it with deep penetration? Deep penetrative pain with sexual activity tends to be more prototypical for endometriosis, and we think this is often related to deeply infiltrative endometriosis in the posterior compartment, so in the areas behind the uterus, like behind the uterus and between the uterus and the bowel, and we know that that can cause significant pain. But we also know that in patients with endometriosis, they're more likely to have pelvic floor myofascial pain, which can also cause significant pain with sexual intercourse. So looking and screening for this on the pelvic exam is incredibly important. Finally, though, there are other causes of pain with intercourse, and pain with entry upon intercourse tends to be more often related to pain conditions that arise from the vulva and the vestibule. We know that vulvodynia or vestibulodynia is one of the most common causes for entry pain, and this condition tends to be more common in women with endometriosis compared to those without. So doing a comprehensive exam for these symptoms is incredibly important, and many of these etiologies are very treatable and can really result in an incredible improvement in a patient's quality of life and relationship when that painful intercourse is adequately controlled. So thank you for joining me for this Ask the Expert session, and I really hope you found this information helpful.